Research Forum. I'm really happy to welcome you to today's webinar on the role of autoantibodies in rheumatoid arthritis joint pain, to be presented by Camilla Svensson. Today's webinar is PRF's 21st webinar overall, and it's the 12th webinar in a new series that we launched a little over a year ago that has been focused mainly on topics in pain drug development and related areas. And we're really excited about today's webinar. It's our first webinar ever on the topic of arthritis pain. So at the outset, I'd like to thank Genentech and MedImmune for providing an unrestricted grant to PRF in support of the webinar series, and I'd also like to thank all of our general site sponsors for their support of PRF as well. For longtime PRF webinar goers, I'm sure you're very familiar with the format, but for those of you who are new, Camilla will present a talk that will last about 35 minutes or so, and then after the talk, our panelists will take a couple of minutes to make a comment on the presentation and/or raise some questions, and then the rest of the time will be devoted to group panel discussion and audience questions. Speaking of which, as always, we have plenty of time for questions, so we encourage you to submit questions at any time to the panel by typing them into the questions area of your control panel window, which is this rectangle that you see on your screen, and we'll get to as many questions as we can. One quick note about audio: if you're using your computer for the audio but you're having trouble hearing, I would recommend trying to switch to the phone, and vice versa. If you're using the phone for the audio but you're having some trouble, I'd recommend switching to the computer, and also just make sure the volume is turned up on your speakers. Usually that solves about 99% of audio problems. So with that said, I now have the pleasure of introducing our moderator, Yvonne Lee. Yvonne is an assistant professor of medicine at Harvard Medical School and also director of pain research in the Division of Rheumatology at Brigham and Women's Hospital here in Boston, Massachusetts. Yvonne, welcome. It is great to have you here today. Please go ahead.
Thank you so much. It's a great pleasure to be here, Neil, for this wonderful talk by Dr. Svensson. So let me now introduce the panelists. The first panelist is Maripat Kaur. She is a professor of medicine at the UC San Diego School of Medicine in San Diego, California. She's an esteemed rheumatologist and translational scientist whose lab focuses on autoimmune and inflammatory joint disease. And we also have Dr. John Lampa, who is an associate professor at the Karolinska Institute at Stockholm, Sweden. He is also a rheumatologist and researcher with a focus on the impact of inflammation, particularly on the CNS and CNS pain regulation. And we also have Dr. Hans-Jörg Scheibel, who is professor and chairman of the Institute of Physiology and Neurophysiology at the University Hospital Jena in Germany. And his research focuses on the intersection between inflammation, neuronal mechanisms, and pain. And so at this point, I would like to introduce our presenter, Dr. Camilla Svensson. Camilla Svensson received a Master of Science in Pharmacy from Uppsala University in Sweden, and then she pursued her predoctoral work at the University of California, San Diego on spinal mechanisms of pain transmission. She received her PhD in molecular pathology from UCSD in 2005, and then undertook postdoctoral work centered on inhibitory regulation of intracellular signaling in rheumatoid arthritis at UCSD. Dr. Svensson started her laboratory at the Karolinska Institute in 2009, where today she's an associate professor and the Wallenberg Academy Fellow and Ragnar Soderberg Fellow in medicine. She leads a research team exploring pain mechanisms in rheumatic disease with a specific focus on the role of antibodies and associated inflammatory and non-inflammatory processes, as well as glial cells in peripheral and spinal pain signal transmission. We're delighted to have Camilla here today to present her talk, The Role of Autoantibodies in Rheumatoid Arthritis Joint Pain. Camilla, please go ahead.
Thank you very much, Yvonne. So, hello everyone out there. Thank you for taking time attending this webinar. So today I will share with you some of the findings from my lab with regards to the potential role of autoantibodies now I changed the slide, right? With regards to the potential role of autoantibodies in rheumatoid arthritis-induced joint pain. So there are many injuries and diseases that trigger a local and sometimes persistent inflammatory reaction in which pro-inflammatory mediators such as chemokines and cytokines are released. So many of these immune mediators can have a direct effect on the sensory neurons and either directly activate or sensitize the nociceptors. So if you imagine that this takes place in the joint, simply walking can become painful, and these sensory changes are, if they are long-lasting, it will cause a significant clinical problem. So another type of immune-related factors that have recently received attention as potential contributors to long-lasting pain states are the autoantibodies. And as indicated in this slide here, the role of antibodies in pain processes have most frequently been attributed to the role in the inflammatory process. That is, after they bind their specific antigen and form immune complexes, they serve as triggers for immune cells like macrophages, neutrophils, and mast cells, and stimulate them to, among other things, release chemokines and cytokines, which can activate or sensitize nociceptors. So it's well established that in conditions like rheumatoid arthritis, autoantibodies do contribute to tissue injury and excessive inflammation, and hence pain. However, findings from our animal studies indicate that antibodies may contribute to nociceptor activation or sensitization also through routes that are not dependent on activation of inflammatory cells. So what I hope to do today is to expand your view on how antibodies may contribute to persistent pain states. So before I go into RA and pain, I just want to point out that there are now a number of reports suggesting roles of autoantibodies in pain conditions that are not directly related to this action on inflammatory cells, but other mechanisms. And that is very nicely highlighted in a recent review by Stephen McMahon. So this figure is from that review. So in addition to stimulating inflammatory cells, autoantibodies may cause structural injury to the somatosensory nervous system and thereby induce neuropathic pain. So one example of this is the Guillain-Barré syndrome. So these patients have autoantibodies against gangliosides. Gangliosides are expressed in the plasma membrane and axonal membrane, and they will direct the autoantibodies to target the neurons and then injure the neurons via, for example, complement fixation or macrophage activation. But autoantibodies may also alter neuronal activity without causing a gross structural injury, but instead alter the functional status of the neurons, leading to hyperexcitability and pain. And one such example is pain associated with antibodies against voltage-gated potassium channel complex proteins. So these antibodies that bind these complex proteins will interfere with the localization and function of potassium channels, and thereby leading to hyperexcitability. And lastly, it has been reported that sensory neurons express Fc gamma receptors. And these Fc gamma receptors are receptors for antibody immune complexes. And these Fc gamma receptors are activated by the antibodies independent on the antigen that they are binding. So this opens up for a completely novel interaction between the adaptive immune system and the sensory nervous system. And I will come back to the Fc gamma receptors briefly at the end of this presentation. So just a brief introduction of rheumatoid arthritis. RA is a chronic, progressive or relapsing autoimmune disease. It affects approximately 1% of the population, and it's more common in females than in males. And it's characterized by joint inflammation. And if this disease is not treated, it will lead to destruction of cartilage and bone. So pain is a big problem for this group of patients, especially during active disease. And actually, RA patients rate pain relief as one of their top priorities for health improvement. And historically, pain among RA patients has been attributed to the peripheral inflammation. And of course, with the success of the new disease-modifying anti-rheumatic drugs, which are quite efficient in controlling the disease activity for a large number of patients, it was thought that joint pain would also be controlled. With the control of the inflammation, pain would also resolve and no longer constitute a big problem. However, there are now several surveys that show that this may not be the case, at least not for subpopulations of patients. Because despite effective anti-rheumatic therapy, when the disease activity is much reduced or in remission, there are still subpopulations of RA patients that continue to suffer from joint pain. So there's not always an obvious correlation between the degree of joint inflammation and joint pain in RA patients. And in addition, joint pain may actually develop before other symptoms of the disease. It's in fact very often one of the very first symptoms of an emerging arthritis, and thus pain can be present prior to diagnosis. And even more strikingly, the autoimmunity may be present for a long time before disease onset. A person can be positive for RA-associated autoantibodies for 5, maybe 10 years before diagnosis. So this dissociation between disease activity and joint pain have led us to ask if autoantibodies, in addition to driving inflammation, leading to pain in RA, also can activate or sensitize neurons through mechanisms that are independent of the inflammatory process. So RA is typically associated with the presence of autoantibodies in serum and synovial fluid. And with this slide, I just want to illustrate that the autoantibodies in RA display a wide spectrum of reactivities against different proteins. For example, antibodies against different citrullinated proteins or cartilage components such as collagen type 2. It can also be stress proteins and enzymes. And we have focused on autoantibodies against citrullinated proteins and collagen type 2 in my lab, and the association to pain that they may demonstrate. So I will spend most of my time on anti-citrullinated protein antibodies, or ACPA, today. So this family of autoantibodies is present in approximately 70% of the patients with RA, and ACPA are specific for RA. The antibodies are directed against proteins that have been post-translationally modified so that the positively charged arginine is converted to a neutral non-standard amino acid citrulline. And this reaction is mediated by peptidyl arginine deaminase, or the PADIs. So citrullation per se has a role in normal physiology. For example, it plays an important role in the regulation of gene expression, as citrullation disable histone methylation. But citrullation is also associated with pathology, for example in MS and Alzheimer's. In rheumatoid arthritis, however, the role of antibodies towards citrullinated proteins in joint pathology is still under investigation. So there's not really a clear correlation between ACPA and the pro-inflammatory reaction. But the presence of ACPA and joint pain or arthralgia before onset of inflammation predicts a more aggressive clinical course of the disease. And in mice, it has been shown that ACPA alone does not induce arthritis. However, if it's combined with other pathogenic antibodies, it may facilitate the development of experimental arthritis. So we decided to examine if ACPA isolated from RA patients induce pain-like behavior after intravenous injection to mice. So in the first experiment, we collected the total IgG pool from ACPA positive patients, ACPA negative patients, and healthy controls. And we did that by running the blood samples from these groups over a protein G column. And in the second experiment, we isolated ACPA from the ACPA positive patients with columns with cyclic citrullinated peptides, so that we got purified ACPA, IgG, and all the other non-ACPA IgG in a fraction that we call for the flow-through IgG fraction. And already the first experiment told us that there was something special about ACPA. So here you can see that the mechanical thresholds to 1-Fray filament stimulation did not change in mice that had been injected IV with IgG from ACPA negative or ACPA negative RA patients or healthy controls. Whereas the mice that were injected with IgG from the ACPA positive patients developed mechanical hypersensitivity detectable 5 days after injection. So this experiment gave us two pieces of important information. First, injection of antibodies in general did not cause sickness or pain-like behavior just because they were a foreign protein. And second, the pro-nociceptive properties of IgG from ACPA positive RA patients differed from the other IgG pools. So only IgG from ACPA positive patients caused hypersensitivity in mice. And in the second experiment, we could couple the induction of mechanical hypersensitivity to ACPA as only the injection of the purified ACPA, but not the remaining IgG from these patients caused hypersensitivity. And interestingly, one injection of 1 milligram of purified ACPA caused a long-lasting hypersensitivity. It lasted for at least 4 weeks. We did inspect the paws and the ankle joints on a regular basis, but we could not detect any signs of joint swelling or redness in any of the experimental groups. So also in our hands, ACPA did not induce visual signs of inflammation. In order to get a bit more insight to what type of pain behaviors can be coupled to ACPA, we also assessed if ACPA injection changed locomotor activity and or thermal sensitivity. So while locomotor activity is not a direct measure of pain-like behavior, we think it's very interesting that mice injected with ACPA, but not flow-through or IgG from healthy controls, displayed a reduced amount of nightly activity already the night between day 2 and day 3. When it comes to thermal sensitivity, injection of ACPA, but not flow-through, led to an increased response to acetone, which indicates cold sensitivity induced by ACPA, and a faster response to heat application, which indicates that ACPA induced heat sensitivity. So clearly, ACPA induced evoked pain-like behaviors and perhaps also spontaneous pain-like behavior. Though we did not observe any injection reaction in response to the human protein, we wanted to ensure that the pro-nociceptive effects that we observed for ACPA was not in any way coupled to the antibodies being human. So for this purpose, we used monoclonal murine ACPA. So these antibodies were generated by our collaborators from B cells isolated from synovial fluid of RA patients. And the B cells were single-sorted, cloned into expression vectors, and then selected for their reactivity to citrullinated epitopes. And in this process, the human FC was exchanged for a mouse FC. So we had monoclonal murine ACPA. And you can see in the table here that these monoclonal antibodies had different degrees of cross-reactivities to the different citrullinated proteins. And this is something that is also very typical for ACPA isolated from humans. E2 is just a control antibody that just is not reactive to citrullinated epitopes. So as you can see here, the ACPA D10 and B2, but not the control antibody E2, caused mechanical hypersensitivity after IV injection, without causing any signs of visual inflammation. Interestingly, C7 did not cause hypersensitivity. And I will come back to this antibody in a little bit. So we are very excited about these results, as they demonstrate that certain ACPAs induce pain-like behavior in mice. And one could say that our studies have provided a pathological property to ACPA. And of course now the next step for us was and still is to decipher how these antibodies are evoking hypersensitivity. What is the mechanism or mechanisms? So as I said, visual inspection of inflammation was not did not indicate inflammation when we injected ACPA, but of course that is a very crude measure of detecting inflammation. So we first asked if ACPA could induce a low-grade inflammation that was not visible by eye, and we did that by examining joints by histology. And you can see here the ankle joint. This is the talus, and this is the tibia here, and the talus, and this is the tibia. And as you can see, there are not really any signs of an inflammatory infiltrate into the synovium of the ankle joint of ACPA-injected mice. And these joints are collected 7 days after injection. So not really any histological sign of inflammation after ACPA injection. We also isolated or dissected the joint and extracted RNA to see if there were any biochemical indications of an inflammatory ongoing process. And you can again see here that we didn't really detect any changes in inflammatory factors such as TNF, IL-1 beta, IL-6 or cyclooxygenase, nor did we see an elevation in mRNA for matrix metalloproteases or mast cell associated proteases. Of course, there could be changes in other inflammatory associated factors, but we concluded from this study that it's not likely that ACPA induced a classical inflammatory reaction after IV injection to naive mice. Instead, we took a different avenue and spent close to a year testing if ACPA could directly activate nociceptors. And in this and the next slide, I will show you that the answer to that is probably no. We did not find evidence that ACPA directly caused a change in neuronal activity, at least not during the conditions that we used. This is calcium imaging in primary dorsal root ganglia neuronal cell cultures. And you can see that we are, when we include either flow-through or ACPA in the perfusate, we could not detect any increase in intracellular calcium in these neurons, even though the cells were clearly responsive to potassium chloride. We also did electrophysiology, and when we did voltage clamped patch recordings from DRG cells, you can see that cells that were responsive to capsaicin did not respond to ACPA. We did not see any change in inward current when the neurons were subjected to ACPA. So we were facing a situation where we had demonstrated that ACPA induced pain-like behavior in mice, but we had no visible or histologically detectable inflammation, and we could not detect any direct activation of DRG neurons. So in order to move forward, we decided to examine how the ACPA were distributed in the mice after IV injection, and to see if they were binding to any specific joint cells in the joint, as we thought that could give us a clue to the mechanism. So in order to trace the human antibodies in the mice, we perfused the mice with saline and collected a number of different organs. And what you see here are the Western blots from that. And it's clear that ACPA can be found in the joint, in the bone marrow, in the DRG, perhaps also in the skin, 7 days after IV injection. But we could also see flow-through and IgG from healthy controls in those tissues. However, it should be noted that flow-through and IgG from healthy controls had a slightly different distribution, as ACPA was not present in, for example, lung and skeletal muscle or heart. I think the most important piece of information from this experiment is that you have the antibodies in joint, bone marrow, and DRG, the ACPA that is, and that in general the antibodies did not cross the blood-brain barrier, because we could not detect the antibodies in spinal cord or brain. So it's most likely that wherever they were acting, the mechanism would be in the periphery, or the action would be in the periphery. So we labeled joint and bone sections with ACPA and flow-through, and our immunohistochemistry here revealed quite specific looking staining of ACPA in the bone marrow. And these cells were also positive for CD68. So based on the fact that the ACPA labeled cells were CD68 positive, that they had multiple nuclei and were located close to the mineralized bone, make us believe that these cells are osteoclasts. And we also did see some ACPA positivity in cells that seem to be osteoclast precursors in the bone marrow. So we didn't detect any ACPA positive staining in the synovium or in the cartilage. It was exclusively in bone marrow. And comparing the staining to flow-through, you can see that there is some weak immunoreactivity with flow-through, but the expression pattern is completely different to that of ACPA. We also assessed if ACPA would label mouse osteoclast in culture. And these cells are not permeabilized, and you can see that the ACPA is labeling CD68 positive multinucleated osteoclasts, indicating that ACPA epitopes are, or the cyclinated proteins that ACPA is binding to, are expressed on the plasma membrane. So the fact that ACPA labeled CD68 positive cells in vivo is very exciting, as our collaborator at the Karolinska Institute, Anka Katrina, Lars Klarskog, and others that are focusing on the role of ACPA in bone erosion and joint pathology had found that ACPA enhanced osteoclastogenesis. So their study illustrated here is based on CD14 positive monocytes that are isolated from blood from healthy individuals. And these cells were differentiated into osteoclasts with the MCSF and rank ligand. And what they found was that when they added ACPA into the cell culture media, the osteoclastogenesis, the number of developed osteoclasts were increased in the cell culture dish. And it didn't matter if the ACPA were isolated from synovial fluid or peripheral blood. Anka's team also examined if the monoclonal ACPA would drive osteoclastogenesis and stimulate osteoclast activity. And osteoclast activity here was assessed by culturing the cells on synthetic calcium phosphate coated plates and measuring the bone resorption area. And this is very interesting, because if you see here BO2 and D10, the two monoclonal ACPA that induced pain-like behavior also induced a bone erosion, or increased the bone resorption area and increased osteoclastogenesis, whereas C7, the monoclonal ACPA that did not induce pain-like behavior, also did not induce osteoclastogenesis or osteoclast activity. So we find this correlation between ACPA that induced pain-like behavior and ACPA that induced bone erosion very intriguing. And during our discussions with our collaborators, we realized that they had, in agreement with our studies, found that ACPA stimulation did not elevate levels of cytokines like TNF and IL-1. However, they had found that ACPA stimulation of human osteoclasts led to induction of release of the chemokine IL-8 on the osteoclast cultures. So when we repeated this experiment using mouse osteoclast cell cultures, we found the same thing. So in mice, you have IL-8 analogs. They are called CXCL1, 2, and 5. And in the mouse osteoclast cell cultures, we found that CXCL1 was the release of CXCL1 was increased in response to ACPA, but not flow through. And we did not find an increase of CXCL2, but of note, just keeping the cells in culture led to an increase of CXCL2. But ACPA did not further enhance this release. So this finding triggered us to go back to our joint extract to see if intravenous injection of ACPA caused a change in CXCL1 or 2 mRNA in the joints. And the answer here was quite striking. So 7 days after injection of ACPA, we found that both CXCL1 and CXCL2 was increased in the joint extract, but flow-through injection did not alter mRNA levels of these IL-8 analogs in the joints of the ACPA-injected mice. And of course, we asked the question if IL-8 release from osteoclast potentially could play a role in ACPA-induced hypersensitivity. So in order to test this, we injected CX receptor 1 and 2 antagonist called reparixin. This IL-8 receptor antagonist was injected subcutaneously once a day for 6 days, and you can see that the antagonist at least partially reversed ACPA-induced mechanical hypersensitivity and completely reversed ACPA-induced heat sensitivity. And it should be mentioned that others have injected IL-8 into ankle joints and peripheral tissues and observed that by itself can cause mechanical hypersensitivity, and there are IL-8 or CXCR1 and 2 receptors expressed on peripheral neurons. So this data is beginning to close the loop. There's one piece of data that I also want to show you, and that is when we looked at bone loss in the mice after ACPA injection. So this is the same mice as I show you here. The bones were collected day 28, and you can see that the ACPA injection caused a reduction in bone density, particularly in trabecular bone. We didn't see an effect in parameters of cortical tissue mineral density. And interestingly, the IL-8 receptor antagonist prevented ACPA-induced bone loss. So in order to see if it was not only IL-8 but perhaps also osteoclast activity correlation to ACPA-induced pain-like behavior, we wanted to assess if reducing osteoclast activity would prevent ACPA-induced hypersensitivity. So for this, we used a bisphosphonate called soledronate. Bisphosphonates are used for treatment of osteoporosis. They induce osteoclast apoptosis. Interestingly, here you can see that when we injected soledronate once a day for 6 days, we could prevent induction of ACPA-induced hypersensitivity. Actually, the highest dose completely prevented induction of ACPA-induced pain-like behaviors. And following the IL-8 story, we also found that blocking osteoclast activity prevented increase of CXCL1 mRNA levels in the joint. So this last slide, the result from the osteoclast inhibitor study, helps us to narrow down our working hypothesis to that ACPA activates osteoclasts and that increased osteoclast activity leads to release of IL-8 or CXCL1 in the mouse, and perhaps also other not yet identified factors that sensitize receptors in the joint or in the bone marrow. So to summarize what I just shared with you, I have showed you that ACPA induce robust pain-like behavior in mice without generating visible or histologically detectable inflammation. I will not say that we didn't find signs of biochemically related inflammatory factors, because of course IL-8 is an important chemokine, especially for recruitment of neutrophils. So perhaps what we see here is the very beginning of an inflammatory process, but when we're only injecting ACPA, we are missing out on other factors that could potentially be necessary for mounting an inflammatory reaction. I showed you that ACPA label osteoclasts in vivo, in joint sections, and that ACPA stimulate osteoclasts to release IL-8 or CXCL1 in mice from cultured osteoclasts, and that blocking osteoclast activity or the IL-8 receptors reduce ACPA-induced pain-like behavior. So clearly ACPA is interesting from a pain perspective, and in addition to that, I think that these data point to that targeting IL-8 and perhaps also osteoclasts may be relevant not only for pain in RA, but also in other diseases where joint pain or altered bone metabolism coupled to pain is an issue. Okay, so with that, I want to spend the next 10 minutes on the other end of the antibody. I have talked about ACPA binding to cytokinated epitopes on the osteoclast and thereby affecting osteoclast activity. Of course, one thing that we really need to sort out is how this effect is mediated. What is the mechanism for that? But I want to draw your attention to also the Fc part of the antibody, because recent work by Georg Schett have indicated that ACPA may also affect osteoclast activity through Fc gamma receptors expressed on the osteoclast. So that, of course, makes us ask if Fc gamma receptors could also be a potential mechanism for perhaps ACPA-induced pain-like behavior in mice, or for autoantibodies in general when it comes to the coupling between autoantibodies and nociceptive signal transmission. So with that, I just want to briefly introduce Fc gamma receptors. There are 4 major subtypes of Fc gamma receptors in mice. Fc gamma receptor 1, 2b, 3, and 4. And of these, 1, 3, and 4 are activating and 2b inhibitory on immune cells. These soluble tyrosine kinase coupled receptors are activated by immune complex. So the Fc part of the antibody is binding to the Fc gamma receptors, and they have to be in immune complex formation for this activation to occur. And they can be activated by different subtypes of IgG. There are already work published on this topic, and Ma and colleagues that at the time were working at Yale in the US have done a fantastic job around Fc gamma receptors and nociceptor excitability. And I will not go through their work in detail at all, but I think that this cartoon really illustrates the conclusion of their work that is published in these 2 papers that I really recommend you to read. So they show that Fc gamma receptor activation leads to intracellular signaling via spleen tyrosine kinase and phospholipase C that release calcium from internal stores. And this will further sensitize or activate TRPC3 receptors so that there's a flux of calcium into the cell, ultimately leading to membrane depolarization. So while Ma and colleagues used non-specific IgGs in their work, we have worked extensively with collagen type 2 antibodies, and our work is in many ways supporting the work by Ma, but we are also extending this concept to in vivo studies. So I thought I'd finish this presentation by sharing with you some of our findings supporting a role for also Fc gamma receptors in nociceptive signal transmission. So first, I just want to show you that Fc gamma receptor mRNA is expressed in both mouse and human DRGs. Both 1, 2b, 3, and 4 mRNAs were identified in the DRGs by mRNA array and qPCR, and also mRNA for Fc gamma receptors in human DRGs were present at similar levels to, for example, TRPV3 and TRPV4 receptors. So we are working extensively with the collagen antibody-induced arthritis model of rheumatoid arthritis in my lab in parallel to the ACPA model. And in the KAIA model, joint inflammation is induced by injection of a cocktail of antibodies towards collagen type 2. And this is a very useful model for studies of pain mechanisms during an ongoing inflammation or in the phase after a resolved flare of joint inflammation. But we are also using this model to try to delineate how antibodies can induce pain-like behavior prior to induction of inflammation. As you can see here, these mice show mechanical hypersensitivity already day 3, even though there are no visual signs of inflammation or histological signs of inflammation at this very early phase of the model. Perhaps more obvious here, we can inject collagen type 2 antibodies without and get mechanical hypersensitivity without any signs of inflammation. Here we used one monoclonal antibody towards collagen type 2, and you can see that when we titrate down the dose of antibody from 2 milligrams and downwards, we get a pronounced mechanical hypersensitivity without any signs of joint inflammation. This is quite similar to what I showed you just recently with regards to ACPA and the following pain-like behavior. However, the collagen type 2 antibodies do not bind osteoclasts. They are strictly binding to collagen type 2. So here we reasoned that as there is often collagen type 2 fragments in the joint, it is possible that there is a local formation of collagen type 2 antibody collagen immune complexes that could activate normally expressed Fc gamma receptors. And we have addressed this possibility in DRG neuronal cell cultures. So in contrast to when we stimulated primary DRG neurons with monomeric ACPA, addition of collagen type 2 antibody immune complex led to increased levels of intracellular calcium in 24% of the cells that also responded to potassium chloride. But stimulation with monomeric antibodies did not cause an increased activity in the primary DRG neurons. We also measured CGRP as a readout for neuronal activity. And here you can, we measured CGRP in the culture media before and after stimulation. And you can see that when we stimulated cells with capsaicin, there's a CGRP release, and also addition of collagen type 2 immune complex evoked CGRP release. But we did not see any CGRP release when the cells were stimulated with monomeric collagen type 2 antibodies, the antigen or control antibody. And we know that Fc gamma receptors are important for the CGRP release here, because when we established GIG cultures from Fc gamma chain knockout mice, so that are mice that do not have Fc gamma receptor 1, 3, or 4, we could still evoke CGRP release with capsaicin, but collagen type 2 immune complex failed to evoke CGRP release. So the presence of Fc gamma receptors were critical in this context. And we also have a recent data showing that Fc gamma receptors are important for induction of collagen antibody induced hypersensitivity in animals. So here, and this is my last slide, you see that Fc gamma chain, or if we start with the wild-type mice again develop mechanical hypersensitivity very early after injection of the antibodies, but the Fc gamma chain knockout mice were completely protected from development of collagen type 2 antibody-induced hypersensitivity. Of course, in this particular study, we cannot say anything about the cellular location of Fc gamma receptor involvement and induction of pain-like behavior. So that is where we stand right now. And we are about to examine animals in which we have depleted Fc gamma receptors, specifically in neurons. And we're also taking a chimera approach to address if this effect is mediated solely by Fc receptors on neurons, or if also other cells are involved. And hopefully I can provide you with the answer to that next time I talk on this topic. So to summarize this last bit, I showed you that joint inflammation is not necessary in order to generate collagen type 2 antibody-induced pain-like behavior, and that collagen type 2 antibody immune complex evoke calcium flux and release of CGRP from neurons in the absence of immune cells, and that collagen type 2 antibody immune complex activation of nociceptor neurons is dependent on Fc gamma receptors, at least in cell culture. So in conclusion, the data that I have shared with you today suggests that particular autoantibodies present in rheumatoid arthritis can induce pain in the absence of classical inflammatory processes, and perhaps osteoclast activity and release of factors from these cells, as well as Fc gamma receptors, are key mediators of this type of sensitivity. Our data suggests new potential mechanisms that may contribute to arthralgia prior to disease onset, and perhaps also to the remaining pain in the RA patients that are successfully treated for their inflammation. It is also suggesting that autoantibodies that are targeting joints and other tissues may cause long-term pain via non-conventional mechanisms, not only in RA but also in other autoimmune conditions. So to target autoantibodies, Fc gamma receptors, or antibody-induced factors may open new avenues for pain relief in painful autoimmune disease. So with that, I just want to end by acknowledge the people that have been involved in this work in my lab. Gustav Wigeblad, Dugo Bas, Alex Versilini-Fainotti did a major part of the work that I showed you today, and Jungo Kato, Katarzyna Rogos, and Katarina Sander also contributed. Of course, this work would not be possible to do unless we had such great collaborations with multiple PIs at the Karolinska Institute and other universities in Sweden and elsewhere. And of course, the funding from different agencies are also, we're also very grateful for that support. So with that, I say thank you and give the word over back to you, Yvonne.
Thank you so much, Camilla, for such a fascinating talk. You have certainly a great body of work there on autoantibodies and pain. We're now moving into the panel discussion and Q&A for approximately the next 35 minutes. I would like to remind the audience that they can submit questions by typing them into the control panel window, and then these questions will be directed toward the panel by myself. So to get the discussion started, I would like to start with our panelists, Maripat, John, and Hans-Jörg, to make some brief comments and or questions regarding the presentation. So why don't we start with Maripat?
Yeah. Hi, can you hear me?
Yes.
Perfect. So I really enjoyed this talk very much, Camilla, and of course this work has significant impact. As a rheumatologist and practicing clinician, often the difficulty we face is individuals who come with pain but no demonstrable synovitis, and these studies really show light into an area that can actually be approached in terms of pharmacology. It'd be very interesting to see if any of the future biologics that block these pathways can actually influence and assist these individuals, and perhaps even an early disease where it could be possible to circumvent any later sequelae. So it really laud Camilla on shedding light into this area and bringing forth these new advances.
Great. And then our second panelist is John. Would you like to comment for a few minutes?
Yes, can you hear me? Yeah.
Yes.
Yeah. Thank you very much, Camilla, for a lovely talk, and I've heard some of this before, of course, and we're fascinated also as rheumatologists, as Maripat said, for having new views of the impact of autoimmunity on pain in rheumatoid arthritis. And I should add there is also a bunch of work as rheumatologists know about ACPA present in the disease about 15 years before onset of the disease, and then we see that different ACPA specificities, because ACPA is just a kind of a summary of all these specific antibodies directed to specific antigens, that this also the targeting, and there is certainly as epitope spreading seen also in several earlier papers before approaching onset to the actual onset of the disease. And it opens up also that we should be earlier and earlier in this disease and focus also on these patients with ACPA and arthralgia that certainly should be more investigated, and there we have also the possibilities to possibly intervene, and that would be very fascinating for the future. Thank you.
Yes, great. And then our third panelist is Hans-Jörg Scheibel. Would you like to comment for a few minutes?
Yeah, thank you for a very nice talk. I think it's also very interesting, innovative data for pain research, and congratulations to the work. I have some questions. For example, if ACPA is existing very long before the outbreak of the disease, yeah, do you see any evidence for osteoclast activity in these patients, or is the ACPA just present and doesn't do anything? This is one open question which I have after your talk.
So it's my understanding, and you, Maripat, you can correct me if I'm wrong, but I think that it has now been shown that ACPA-positive individuals have signs of altered bone metabolism, so that you could perhaps have a change in osteoclast activity before you actually develop the disease.
But is it the first? in the initial stage of rheumatoid arthritis, the destruction of the bone, or is it a later event? What is first? What's coming first?
I could add something there. It's not known, of course, what comes first, but it's like Katrina's group has also shown that rank ligand correlates very well with ACPA positivity, and high ACPA correlates with a high rank ligand. But of course, that's an open question. What comes first in this context?
Mm.
Great. And so now we do have a bunch of questions coming in from the audience. And so I would like to start with one. This would be directed towards Camilla. So the question is, RA and associated pain are much more prevalent in women. Do you see any differences in these models in male versus female mice?
Yes, so we have injected the ACPAs both in male and female mice, and we get very similar changes in mechanical thresholds. So in the experimental setting, there's no difference that we have detected yet between male and female mice.
Great, great. And then another question was, have you shown that your ACPAs are specifically binding to the citrullonated form of the protein and not the native form as well? And the reasoning behind this question was in the questioner's model of complex regional pain syndrome, they did see ACPAs binding to citrullonated proteins, but unfortunately they were indiscriminately binding to the native protein as well. And so it seemed that this was unique to mouse ACPAs and human ACPAs. So that was the question.
Yeah, so Vivi Malmström and colleagues at the Karolinska Institute that are either isolating the antibodies from our patients or developing the monoclonal antibodies, of course, are testing the specificity. So as I mentioned, we know that there is a great deal of cross-reactivity between citrullonated epitopes, but these antibodies that we have been using, the monoclonals, for example, they are selected based on the fact that they are not recognizing the native, the arginine form.
Okay.
So that, yeah. So the monoclonal antibodies would answer that question. Yeah.
Great. And then a couple more technical questions before we get to some bigger, broad questions. One was, how is the collagen type 2 IC prepared?
Say that again? The collagen
how
type
is
2?
The collagen immunocomplexes prepared?
Yeah, so that is by mixing collagen type 2 with the collagen type 2 antibody at a ratio 1:1. It's then incubated shaking for 30 minutes. And our collaborators, Rikard Hondahl and Nanda Kumar Kutiselva, have developed this protocol for making collagen type 2 collagen immune complex. So that has been validated.
Great, thank you. And so now I'm going to go to some more of the bigger, broader questions that the audience has, and perhaps direct some of them to the panelists, perhaps Maripat, John, or Hans-Jörg. What do you think about this antibody approach, and do you think it will be relevant to other types of joint pain beyond rheumatoid arthritis? Maripat, perhaps you can start.
Well, the antibody approach I think sheds significant light on mechanisms that cross periphery into perhaps central pain, where here Camilla didn't detect any direct central antibody binding, and of course antibodies don't cross the blood-brain barrier. So it's also feasible perhaps to treat pain in a similar way. So if we can use and work these mechanisms and how we can approach it not only in the pathophysiology, but as we develop our biologics and further direct our therapies. So there's the direct mechanism of antibody, but perhaps we can also block substantial pain without having to directly cross the blood-brain barrier. So there are a lot of implications in this work, both direct and indirect, and looking at the smaller scale, I think that antibody mechanism really accounts and attributes for clearly a component of the pain, and whether or not that's in the cascade of then pushing cytokines and then perpetuating other mechanisms downhill, that really remains to be seen. And whether or not the individual antibodies in themselves are related to this pain is another question. If you notice, the monoclonals that commonly used and all have the same efficacy in directing pain. The ones that seem to have more vimentin reactivity seem to have the better ability to direct pain than others that seem to have other specificities. So there are a whole host of questions whether or not you have to actually develop an epitope spread to a very distinct and specific epitope, or if you have a multiplicity of antibodies, does that then push you over the edge? So as always, there are way more questions than there are answers in how this field is going to evolve.
Yes, certainly there seems to be many, many, many more studies out there that this line of work is fostering. John or Hans-Jörg, do you have any comments on this?
I have one question. Probably there are a lot of antigen-antibody reactions going on in our body, but we don't realize most of them. So what makes the reaction painful, and why are many reactions probably not painful? This is, I think, an open question.
Yeah, I would agree that that is an important question. And of course, our current hypothesis is that you need a local immune complex formation that is in the vicinity of nociceptors, reaching concentrations that are high enough to actually activate the Fc gamma receptors expressed, if it's Fc gamma receptor mediated on those. But I agree with you, and for example, one thing that I've been wondering is when you have Hashimoto, you have autoantibodies targeting the thyroid, and that is not painful. But I also don't know how is the thyroid innervated with the pain fibers. So we need to understand this relationship very closely.
So we need probably to understand additional conditions, yeah, which are necessary.
Absolutely.
Yeah,
absolutely.
So, yeah.
I can comment.
So one more.
Yeah,
go
I
ahead.
can comment on the clinical side of autoantibody impact on pain. I mean, in rheumatology, if we make it a bit broader, we have several diseases. I think that is also what the question may have been about originally from the audience about autoantibodies in several rheumatoid diseases. And for example, in lupus, and we have the SSA, SSB antibodies. We have a lot of specific reactivity causing autoantibodies, and we in these diseases we also have several pain conditions and generalized pain evolving. So I think this also opens up that we should investigate a lot more in these diseases, this mechanism, because well, from Camilla's work, it has been very directed to ACPA, how it influences pain sensitivity in mice compared to the flow-through. But this is also very directed that it's autoantibodies against not autoantibodies, so to say. So I think it needs to be also broadened. This is it more like an effect of autoantibodies to several antigens, or not only, and that ACPA is one of them, so to say. And this will be also one line of research in digging out the autoantibody impact on pain generally in autoantibody dependent diseases. I think that will be an interesting feature.
Great. And so one of the audience questions was also, given, the role of the osteoclast in all of this, could you use this antibody approach for patients who may also have osteoporosis and are taking, for example, denosumab, another antibody? Any thoughts on, like, as John was saying, going to another disease state, now looking at osteoporosis, how this may affect that?
So I think if you look at osteoclast activity, we know that there are several conditions where you have bone pain, if you want to call it that. You look at bone cancer, perhaps during fracture healing and so forth. So there are other conditions, and osteoporosis perhaps especially very much so after a fracture, where you have an altered bone metabolism, and that leads to long-lasting pain states. So to target osteoclasts, I think could be one approach, and that should certainly be investigated. Though if you look at ACPA or autoantibodies, that is not known to be a mechanism of osteoporosis. So to target antibodies, I don't think would be a relevant approach. But to target the osteoclast would certainly be.
Right. And so kind of along those lines, another question was, could measuring ACPA be a new way to diagnose RA or similar pain conditions such as fibromyalgia? So I know in RA we do use CCP as a way to diagnose RA now. We don't per se clinically look at the various subsets of the different types of citrulline proteins. And you mentioned, Camilla, in one of your slides how I believe a certain clones were associated with increased mechanical sensitivity following injection of the monoclonal ACPA, but others were not. And it seemed like some of those may related to the different types of citrulline peptides. Is that true? And then what are your thoughts on that? Like, can we then measure the different types of citrulline peptides? And might that tell us something about how our patients potentially in the future are going to do? Are they going to develop this residual pain independent of the classical inflammatory pathway, or what implications that might have?
Yeah. No, certainly that is what we are finding. And we have tested other monoclonal ACPAs as well, and it's a pattern we see that not all citrulline epitope or antibodies against a certain spread will cause hypersensitivity, while other ACPA clones are monoclonal clones are very potent inducers of hypersensitivity in the mice. And I know that there are also studies that have suggested that certain ACPAs actually are anti-inflammatory. So if you look at the patient situation where you have an epitope spread and a certain collection perhaps of ACPAs, it will be important to understand which citrulline epitopes can be coupled to hypersensitivity, because I don't believe that all citrulline epitopes or antibodies against those will cause pain. So perhaps we can have in the future, if it's possible, if you would have a profile of ACPA specificities that could tell you something about the risk of developing long-term pain or bone erosion, for that matter.
Yeah, great. And then kind of along those lines, I think Maripat may have alluded to this earlier as well. I think some studies have shown that treatment with disease-modifying anti-rheumatic drugs reduce ACPA titer in RA patients, and that this may differ depending on the specific drug used and the specific mechanism of action used. So have you thought about that and looked at, are there any thoughts about looking at different drug mechanisms and seeing whether they may alter ACPA-induced hypersensitivity? One of the audience questions was specifically asking about Plaquenil.
Yeah, of course, that would be very interesting. And one thing that I would love to do would be to have a model where we don't have to inject the ACPA, but perhaps immunize against citrulline proteins or peptides, so that we could then monitor what would happen if we, for example, reduce B cell activity and so forth. So I definitely think that that is something that we want to explore from different approaches in the future. And I don't know, Jon, if you want to say anything about using registers and looking into the correlation between ACPA and pain, and ACPA titers and remaining pain.
Yeah, absolutely. I think I was going to ask you the question too about what you think, knowing from like.
Ongoing work. I couldn't say too much about
Hello?
it, but of course this is what we need to do with the correlation between different ACPA specificities and pain. But this is ongoing. I couldn't say too much about it, but we're currently coming to more and more sense of this, making sense of this. Yes.
Yeah, and I guess thinking about translating the work from basic science to patient population research and things like that, thinking about what are the next steps there. What do you, Camilla, and the panel think about that? Because it seems like it should be relatively easy to look, for example, at seropositive versus seronegative rheumatoid arthritis patients and see whether there are differences in pain sensitivity there, or doing a panel of citrullinated peptides and seeing if there are differences in pain sensitivity or with response to specific drugs, for example. Any thoughts from the panel on where we should go?
May I ask a question concerning?
I think we have been, yeah. We are, sorry, we have been dealing with this question a lot because in the registers where we have thousands of patients and we have them characterized with the ACPA specificities, but we do not have pain, this kind of more quantitative sensitive testing on all these patients, but we have more epidemiological data, and pain is very coupled to inflammation, and this is quite difficult to discriminate. And that is really a target it's a challenge for us in this. But I think what we need, if we want, I think it's also important to go to the very early stages. And for example, you may know Bob Tack showed some data recently that he targeted arthralgia and ACPA positive arthralgia with no inflammation, present inflammation in the joints, and then this was actually they were treated with rituximab. And this was maybe a bit controversial to treat these patients in this way, but he could show that they delayed the onset of kind of the classical RA, showing classical RA criteria. And this is in comparison with, you know, this, there's an old, couple of years, 10 years ago, it was a study from the Leiden group, I think, was in Netherlands, about delaying RA diagnosis in undifferentiated arthritis with ACPA positivity, reducing methotrexate. That was not the fact in ACPA negative patients. But I think this also, this Bob Tack group study shows that we should be able to go further into these very early stages, and that is perhaps where we also should study our pain effects of ACPA before we have all these treatment effects.
May I just ask, how is it known how many patients which are ACPA positive do not develop any problems in the joints? Is that known?
No, it's not known. These studies are. I hope Maripat agrees with me that these studies are ongoing in the population materials. But it's actually a lot of people actually in our hospital would have studied a lot on, for example, on twin registers. We have a study also from Katrina's group on 13,000 twins, and there they can, from the population, and there they can isolate 130 RA cases or something, I think. And that was a good way of doing a population study, and they could then look at the sensitivity, specificity, of course, of ACPA, but it was also evident that very high titers of ACPA really predict RA in a very very high way. Yes, but low titers is not totally predictive. But these more general studies have to be being done, because all these patients, or here it was like if they were having at least arthritis. But what you mean is if they have only ACPA and no joint pain at all, how predictive that is for RA development, and I don't think that has been totally elucidated.
Yeah, I don't think that has been completely answered, but certainly Mike Kohler's group and his collaboration with the Stanford group, where they have first-degree relatives, and they actually mapped out various epitopes of individuals. They tried to ascertain, as you accumulate ACPA epitopes to the point where then you manifest clinical disease, was there one specific epitope that pushed you into clinical manifestation? And they actually did not find any smoking gun. There was no specific single ACPA that then pushed people. They had various rising titers and various different epitopes, but they didn't pull out, for example, pain as an isolated phenomenon specifically. And I think pain might actually be a whole different question than synovitis and are you manifesting inflammation. Because as Camillus' work shows, you can have pain in the absence of clinically apparent inflammation. So I think that really remains a different type of question. Is the pain a form fruste, where we're not seeing peripheral synovitis, which is the thing we usually target to treat, and the usual inflammatory markers. So this question is, I think, different than what the published first-degree relative and ACPA studies were really asking. So it deserves a second look to see if there is something else here.
Right, and I think Camilla's work really challenges us, or as clinical researchers in rheumatology, clinical researchers particularly, who have historically had such a focus on the inflammatory pathways, to really perhaps better study pain, to find better ways of phenotyping and assessing pain in these bigger observational studies or in these clinical trials, so that we can answer some of these questions. Because I know there are a lot of, well, at least a couple studies of ACPA positive arthralgias and treatments for them, whether it be Plaquenil or what have you going on right now. Wouldn't it be great to introduce some pain measures in those studies and to really test these questions? So I just have two last audience questions, and then we need to probably start winding down here. There's been a huge amount of interest in this topic. So the first question was, let me find it here, with regards to the autoantibody approach, are there concerns for side effects, adverse adverse effects and consequences of using an antibody approach for joint pain. And I think another question related to that was with regards to anti-NGF therapy and its role. It's being in clinical trials for osteoarthritis joint pain and the side effects that have been shown in those trials. What role might that have in RA pain or other types of arthritis? Would any of the panelists like to take on this question? Camilla?
That's a
very big question, but if I look at the NGF, for example, I think it's now established more or less that targeting NGF is a very efficient way of reducing osteoarthritis-induced pain, but that if you combine, you have to be very careful with what you combine the anti-NGF treatment with. That if you block at the same time prostaglandin production, there is an increased risk of increasing the disease progression in OA. So it's clear then from that study that when you're targeting one factor, you really have to understand if that factor is involved in normal physiology and maintenance of the joint status. And in this case, with NGF therapy, it indicated that perhaps the highest dose of NGF blockade would also accelerate the disease progression, but not in this clinical trial, but not the other lower doses, and that it really was a combination of NGF blocking therapy together with prostaglandin reduction of prostaglandin production with COX inhibitors that was detrimental for the joint. So of course it's always about understanding the complexity of the disease, and together with normal physiology to know which factors that are safe to target. And the first part of the question, I didn't quite get.
Oh, it was about side effects from the antibody approach, any adverse. So you kind of addressed it along with the NGF question. And so then the very last quick question, and then I'm going to go down to the panelists for their final remarks, was did you use any weight-bearing type of measurement for joint pain?
So we did not in this study. The reason for that, actually we are assessing that right now, but the reason for us not using that in this study was that we have polyarthritis. So remember, we are injecting the antibodies systemically. So, sorry, not polyarthritis, but we're injecting the antibodies systemically, so we are not expecting to have any type of unilateral effects. And then it's harder to use weight-bearing. So weight-bearing, I think, has been very successful as a measure when you have, for example, inflammation in one joint, so that the animal is preferring to not use that joint and instead using the other 3 joints. In this model that I showed you now, the ACPA model, there we have mechanical hypersensitivity bilateral, so on both sides. And it's hard to test the front paws, but I would expect that you might see sensitivity, increased sensitivity also there. And then the weight-bearing assay is harder to use. What you could expect to see is perhaps a change in the gait, but just weight distribution is much harder to assess. I don't think it's meaningful actually to use that test unless you have a unilateral injury.
Okay, great. So we have 4 minutes left. So I'm going to 4 minutes, ask each of the panelists if they have any brief comments in conclusion. So let's start with Hans-Jörg this time.
I think it's a big progress that now rheumatologists and pain researchers talk to each other, because it's the 2 sides of the same problem, and these things have not been connected in the past, and I think this is a big advantage. Gives us a big chance to understand things better, the arthritis and the pain, I think.
Yes, absolutely. John?
Yes, I agree. Very good to have this closer collaboration between pain researchers and rheumatologists. I also think that it opens up for a lot of more work to do also in the clinical side, because now this was experimental studies, but we need to confirm more about the actual relation between ACPA autoimmunity and pain in the clinic, and this will be very interesting to continue in the future furthermore.
Great. And then Maripat?
Well, thank you. So I think this is, of course, a huge field that's just really opening up to us as rheumatologists. Pain is one of the 5 cardinal signs of inflammation, and yet has been very difficult to address with current tools. And certainly these collaborations will bring forward, I think, new therapies. I find Camilla's work highly intriguing, that now we're showing how actually specific elements of the adaptive immune response can then trigger inflammatory cascades in the innate immune response. And perhaps in this crossover effect, we really have opened the door to new ways of approaching therapies as we're coming along with all these new biologics and kinase inhibitors and other small molecular weight molecules. I really see this as one of the advancing wave fronts, and certainly this has been very exciting research.
Great. Thank you all to all the panelists, and definitely to Dr. Svensson. Neil, back to you.
Thanks, Yvonne. As we wrap up here, I'd also, on behalf of PRF, like to thank you, Camilla, as well, for a great talk today. Thank you so much for bringing this area of research to PRF readers and listeners. We also thank our panelists, Maripat, John, and Hans-Jörg, for a great panel discussion, and Yvonne, thank you as well for being our moderator today. And we thank all of our attendees for listening in and for submitting your questions. Just one final note, we'll have a recording of the webinar available within the next few days on PRF. So if you'd like a replay, or if you have any colleagues who might like to listen but weren't able to attend the live event, they'll be able to access the recording shortly on PRF. So with that said, we really hope you enjoyed the webinar today. Thanks for attending, and hope to see you at the next one. Take care, everyone. Bye-bye.
All right. Thank you.
Bye.
Bye-bye.
Bye. Thank you all.
Thank you. Bye.
Bye. Thank you all.